Hello and welcome to another episode of the Mini Battles E-Series by Athens Moderators. My name is Manos Brilakis and I am the head of the scientific and organizing committee of this course. And being driven by our passion for continuous education, development and communication with our international friends, we came up with the idea of launching monthly webinars dedicated to shoulder pathology and treatment, the Mini Battles E-Series. So counting down until the next Athens Shoulder course, we hope to welcome you and host you live in person in Athens in next May.
So let me welcome you as well. I'm Manos Antonogiannakis. I'm the chairman of the Athens Shoulder course. 2 years ago, when we decided to postpone the Athens Shoulder course for 21, we said that it was a nice idea to be able to meet with our friends and discuss interesting shoulder issues every month. And so we started these mini battles, and we are now very satisfied from them. We have a very nice time, and although we are going to have live our course, the 5th Athens Shoulder course on next May, we still think that it's a nice idea to continue these mini battles. Thank you. And before introducing our guest, take a moment to vote for our first poll question.
Which is the following: during the last 12 months of your practice, in how many recurrent instability cases you augmented your arthroscopic buccal repair with ASA, remplissage, DAS, or other similar treatment option? A, never. B, in up to 50% of my case. C, in more than 50% of my case. D, always. Please take your time and answer. So today's episode, the episode number 4 months before the Athens Shoulder course. This episode is dedicated to instability and the augmentation of the classic buccal repair, and we will discuss this subject with 4 exercise surgeons and 4 dear friends, which are the following: Professor Marco Maiotti from Naples, Dr. Gonzalo Samitier from Barcelona, Spain, Dr. Geoffroy Nourisatt from France, and Dr. Christos Koukos from the Greek guy from Germany.
Hello. So, welcome to this episode of the mini battle with those dear friends, and don't forget during the session to submit questions, because this will make much more interesting our discussion. Okay. So let's.
Marco, please start your presentation.
Okay. Okay. Thank you very much to all of you. And this is my presentation as augmenting buccal repair. Everyone knows that the risk factors for arthroscopic buccal repair failure are big bone defects, capsular tissue deficiency, shoulder repair laxity, very important, and kind of sports, with contact sports. And in this situation, the possibility of recurrence can go up to 50% of cases. And we have bipolar bone loss, glenoid bone loss, and humeral bone loss, the Ilsac lesion. And now there is a new concept, but right now I think that to calculate exactly if the humeral head is on off track right now is, I think, a little bit of philosophy, because we don't have an objective way to measure it. So sometimes the measure of these defects are not so exact. And as I told, even especially for the off on track, but of the Ilsacs, but even for the glenal bone loss, because actually it's very difficult to understand which is the cutoff to see if you can have probably a recurrence. The other thing is the other fact that predispose a recurrence is the capsular deficiency. You can see here, if you do a bunker repair, there is no tissue. And now let's talk about constitution, and we have this kind of hyperlaxity. This is a general hypermobility that is asymptomatic. And then we have hyperlaxity that is acquired, constitutional, or multidirectional. But let's talk about the acquired hyperlaxity. When you do this kind of sports, you can have, especially when you begin this sport when you are a child, you can become like that. And then, but you have a constitutional hyperlaxity, and it's hyperlaxity that is anteroinferior, and it's very inferior, and it's anteroinferior, and it's in the shoulder, not in all the joints. And in the as you can see, I studied very much this argument, and I can see that if you go in your office and you do a diagnosis, an accurate diagnosis, you can find many people that have this predisposition, and when you have this predisposition, you ask the patient, how was the first dislocation? And he says, I didn't have a big trauma, and I feel the humeral head pop off the joint, and so there you can suspect that you have an anteroinferior hyperlaxity. The inferior hyperlaxity is you can find with the Sulcus sign, and you have an elongation of the glenor, the coracohumeral ligament, that is very important for the stabilization of the inferior and of the translation of the shoulder. And this is another anatomic slide that you can see even the relationship between the coracohumeral ligament and the other anatomical structure. And another part of the shoulder districtual laxities is the anterior laxity, and you can find this French test called Coudin test. When you do it with the arm in adduction, you externally rotate the arm, and if you have a rotation more than 85-90 degrees, you have an anterior laxity, and you have this kind of anatomical side that you have a thin capsule. Sometimes the labrum is hypoplastic, and here you have the anatomic predisposition of an anterior dislocation. Another thing that this is another paper where you can see that the way they stated that the anterior capsular stretch after repetitive glenohumeral dislocation associated with laxity might be the essential lesion that permits the glenohumeral dislocation. This is an opinion, a very important opinion. The other factor is contact sports. There are sports that are risky sports, and so here, if you do a bunker repair, you have a high percentage to have area dislocation. Another important factor is when you have multiple dislocation, you have anterior capsular deficiency, but usually when you have this, you have an elongation of the subscapularis tendon. And this is, I found all these papers that in the history stated this. So we have to know that, and we don't have to forget this, that the subscapularis tendon does not behave always the same, and the anatomic situation of the subscapularis tendon after shoulder dislocation is different from a stable shoulder. And as you can see, if you go in the shoulder and you stretch it up the subscapularis, when there is that situation, you have an hyperelasticity of the subscapularis, and here is the normal subscapularis tendon, where you can see you cannot pull it up. So in conclusion, when you have to do an exact diagnosis, you have to ask the patient how was the first dislocation. You have to do a clinical evaluation to see if there is an hyperlaxity. You have to do a natural MRI. A simple MRI is not important, is not sufficient, and you have to measure as much as you can the bone loss. Now let's go into the subject. A long time ago, Lenny Johnson in 1986 stated that in chronic recurrent dislocation, sometimes you can find virtually non-existent glenohumeral ligament. This is a phrase of what he wrote, and he said shoulder stabilization has to involve the upper third of the subscapularis tendon. He did with this staple anchor. He used to do even bunker repair with the staple anchor. But this staple were mobilized in the shoulder, so this technique was abandoned. From the idea of Lenny Johnson, I thought he did like that. Now I want to, now without doing the staple, there are other kind of stabilization other ways to do a stabilization of soft tissue, this modern anchor. And so I start doing what Lenny Johnson thought. And so I start grabbing the upper third of the subscapularis tendon, augmenting the capsular that was not sufficient. And I published this article, and I gave the name of the to my idea, the ASA technique, that is an arthroscopic augmentation of the subscapularis. And these are the anchor that I used to use. Now I use an anchor that is a little bit smaller with the labral tape. This is the first tape. Now I use a labral tape, but there are new generation suture anchors. Now there are some knotless anchor that you can use that to do the tenodesis. This is the technique. You always have to repair the capsule with 1 or 2 anchors, and then you grab the upper third of the scap, and then you pass the upper third of the subscap with the tape, and you retrieve it from the upper cannula. You pass it on the lower cannula, and then you do a loop, and you fix the subscap. Usually you have to fix it a little bit up at 10 o'clock or 2 o'clock. Sometimes if the subscapularis is very lax, you can do it. You can put it even at 11 or at 11 o'clock. So this is a few steps how to do it. You have to do the whole over the top position of the glenoid edge, because you have to have a good bone stock, a little bit. You have to penetrate the tendon at least 5 millimeters from its upper border, almost at the same level of the glenoid surface, so you don't have to you don't tie too much the subscap. Here is the position, and you have to use a tape because ASA is a tendon fixation, it's not a capsule fixation. So it's like to suture the calf, because sepsoscap is it's a tendon. So you have to use a tape, and here is the fixation. It's very, very tough, and you can help to do a good scar tissue. And you tie it on the upper third of the capsule, as Manos told. You restrict the rotator interval. You can. This is a view from up. You can see this good bundle that goes around the humeral head. Before, you can see here, no capsule. So if you grab this capsule here, you have a very even 70-80% to have a recurrence. And so you grab this little capsule, you put it here, and then you do the tenodesis, and all the subscap goes and help the scar, help even the scar tissue of the capsule. Now, some considerations. We believe that ASA procedure may reduce the humeral ligament length and reduce the capsular volume. And this is we did not publish the results, but with the play to do these investigations, and we thought with the ultra MRI before and after, and we see that ASA reduce the capsular volume and restore and get a big scar in the upper third of the anterior capsule. And we did with German friends in Germany with the University of Tübingen, a biomechanical study, and we find that the ASA is more effective than banca repair in stabilizing the shoulder, with a reduction of the anterior and inferior translation. This is very important. And some colleagues in Sweden, they did the same experience. And so we published another article, and with my friend Rafael Russo, and he found that the recurrent rate of ASA plus banca repair is equal as the one of the Latarjet when the indications are correct. Obviously, that you must not use ASA every time, but you have to do you have to have the exact indication. I don't think that you can do the same surgery for every kind of dislocation. Is the same thing that you should not use the same cloth for different seasons. So and I explain this later. We think that the ASA acts in the opposite way of the remplissage, because when you do the tenodesis pushes the humeral head posteriorly, so reduces the possibility of dislocation of the Hill-Sachs. The remplissage pulls the humeral head backwards. And so this is an opposite action, but with a different way. You push and you reinforce anteriorly where there is the pathology. This is, as you can see, a slide. You can see that this is the big band that pushes the humeral back posteriorly. So you recenter the humeral head in the right position. We did an investigation because one of the frightening of the using the subscapularis tendon of the and then I will explain later that this is not the historical surgery that was using the subscapularis, we don't find any problem of arthritis at follow-up. And so you should not be afraid to use the subscapularis tendon any longer if you do it like that. And we published another article in the journal Shoulder Elbow with good results. And so the indication. So as I told before, when we use ASA, when someone should use ASA, when you have an hyperlaxity and capsular deficiency, when we have a Glenn-Boyle-Offs, obviously, when it's not, as I told, that we don't have an exact way, and I hope when in the future we will have 3D systems that will show exactly how is the GBL, but when you have a GBL less than 15%, you should have a satisfaction with this surgery and in contact sports. So ASA plus banca repair represent an effective option when the Latarché could be an overtreatment. I think, this is my modest opinion, that sometimes they people use Latarché because they don't know what to do, and so they say, okay, I don't know what to do, I'm afraid that you have a dislocation, I do the Latarché. But doing the Latarché, I think that Latarché is a wonderful technique, but as I told, you sometimes you use the Latarché because you don't know what to do, and you don't address the real pathology with the Latarché. And this is a consideration of my friend Badi Sawa, and I have to tell Manos that I am very happy that Dr. Savoy, in your meeting, the last your meeting in Greece, will give me his compliment of this idea, and he wrote in a podcast in last September, and he said this opinion that has a triple effect. These are the words of Batisawa. Address the stretched part of the subscapulari, restore the capsular insufficiency, and restore the coracohumeral ligament tension, as Manos was saying 10 minutes ago. So it will work, this is very important, without causing external rotation restriction. And this, we publish another article that to show that the external rotation is not compromised. As I told, the historical surgeries like Potiplat or Maxtac were open surgery dealing with the entire tendon, shortening it and causing a problem to the external rotation. But ASA is a completely different surgery. We published in last July a multi-center study, and we on 397 patients at mid-term follow-up with 4% of dislocation. In this, with this indication in athletes with shoulder hyperlaxity. So 4 reasons why to do ASA: low learning curve, low recurrence rate, low complication rate, very, very important, and high opportunity for new surgery. This is another very important, because if you do a Latarché and you have a failure, what you do? This is the result at 5 months post-op. You can see no restriction of external rotation, a very good stabilization of the shoulder. This is another case. This is a very risky sport. At 4 months after surgery, this is the guy who has been get the operation, is with the white helmet, and he sent me this video for tell me thank you about for his operation. Now, this is very interesting. I had a guy, very traumatic redislocation. This is what you can see at the scope. This is the tape that failed, but you can see there a big scar tissue of the upper third of the joint, and so that's why you restore the coracohumeral hinge tension. You can see the tape. The subscap is in good safe, and now you can redo another technique with capsular reconstruction. So you can redo it if there is a failure because there is a big traumatic redislocation, and you go inside and you find that the structure are already there. You can do it again. This technique is they are doing it in China. This is the professor Wentao Zhang that published this article and with the very, very good results. This is an editorial comment of my friend Pietro Randelli on arthroscopy, and I am very proud for this. And he said, in conclusion, I think that the ASA technique can be an appropriate augmentation in cases of anterior shoulder instability and hyperlaxity, especially in athletes. And this Manos is, I want to put this picture because this was the last international meeting that I participate before all this mess. But I think that we can be again in Athens like 2 years ago. Thank you very much, Manos.
Thank you, Marco, for your industry presentation and for reminding us these moments. Before moving on to Gonzalo's lecture, please have a look at our second poll question, which is the following. It's an hypothetical case. When treating patients with a glenoid bone loss of 10% and a small Hill-Sachs lesion, how often you perform soft tissue procedures? The option is A, never. I go straight for Latarjet or some alternative. B, in up to 50% of cases. C, in more of 50% of cases. And D, always. So, Gonzalo, please continue with your presentation.
So, hello, good night, everybody. Thank you, Manos for the invitation. Congratulations, Professor Maiotti, for your presentation. And now I'm going to be the advocate of Remplissage. I'm going to be as objective as possible. The good thing with Remplissage is that we have a lot of literature from many, many years and a solid studies that reinforce the idea that augmenting the banker with Remplissage is very useful in selected patients. So what is a Remplissage? Remplissage is a tinnitus of the infraspinatus tendon to the Hill-Sachs defect in a patient with anterior shoulder instability, as we can see in the picture. The question about when to do a Remplissage is not very difficult. We are going to choose this technique in off-track Hill-Sachs or in a very limiting on-track Hill-Sachs, but in that area that Ito showed us that it can be very dangerous as well. So if we have in zone 4 a peripheral track in a non-track injury, we're going to apply also a Remplissage. The Remplissage is not for patients with critical glenoid bone loss, which normally is accepted over 20-25% of anterior glenoid defect, and also it may not be the best indication for Hill-Sachs, too large Hill-Sachs, more than 30% of the human head. The problem, as Professor Maiotti said, is that we don't know exactly what is the critical anterior glenoid bone defect. Most of us, we're going to accept over 20-25% for sure, but as we have seen in many studies, for some patients, 10, 13, 70% is going to be the critical glenoid bone loss defects, and they can redislocate with a soft tissue procedure. So that make us difficult to take a decision with any soft tissue procedure. And we cannot control or we cannot define exactly these risk factors, especially in contact atlas or collision atlas, patients with hyperlaxity or bad soft tissue in the anterior aspect of the shoulder, and also revision situations. It's very difficult to stratify the risk of these patients with the soft tissue procedure. So that's why I understand sometimes that we go in some situations that we are adapting what to do, and we go straight for the latter jet, because we cannot control all these variables in a very precise manner. What is the effect of our Remplissage? So it's going to convert intra-articular, off-track, engaging Hill-Sachs lesion in an on-track extra-articular, non-engaging Hill-Sachs. That's the key of this technique. It's going to center the humeral head, and it's going to reduce, likely, but not clinically relevant, it's going to reduce external rotation, which reduce the risk of redislocation in many of those patients. What are the benefits of doing a Remplissage? We have seen it in many, many studies from many authors from different institutions, which that gives more credibility to any technique. No? You have different authors that they are not connected, that gives you more confidence in the technique, that the results are consistent. With the Remplissage, we have consistently found in literature a lower recurrence rate when we compare it with isolated Bankart, and increase postoperative clinical scores. As you can see here, we have a bunch of systematic review and meta-analysis, and most of them, the recurrence rate is between 0 to 20%, but most of them are below 6% of redislocation rate, and at least 4 to 5 times lower redislocation rate when we compare to isolated Bankart. Regarding the inclusion criteria on most of these studies, as I said, they are in subcritical or below 20-25% glenoid bone loss defect, of course, but other than that, they include any kind of patients in this study, athletes, they include hyperlaxity, etc. So they don't differentiate here, most of the studies. We also have randomized prospective control study, not many, I just could find this one. This work from McDonald this past year in 2021 in June. They randomized 108 patients, 54 Bankart and 54 Bankart plus Remplissage, patients with a glenoid bone loss defect below 15%. They follow them for 2 years. As you can see the graphic, there is a curve positive for Remplissage compared to Bankart. And as you can see, the Remplissage group, they keep the results over time. And that's different. The Bankart, as we know in literature, it shows us that over the years, even after 3, 4, 5 years, some of these patients with isolated Bankart, they are going to redislocate. And normally, it doesn't happen as often with the Remplissage technique. The final conclusion of this study, the recurrence significantly reduced, as we saw in the meta-analysis and systematic review, from 4 to 18%, the comparison. And they also demonstrate that there was external rotation limitation at 12 months, but this external rotation limitation, it was equal in both groups at 24 months. They also didn't find any difference regarding the posterior superior pain that in literature, some studies, they show that Remplissage can cause some pain. In this study, they couldn't find a difference between Remplissage group or the isolated Bankart. We also can ensure long-term results with our Remplissage. The results, they do not deteriorate over time, clinical scores, redislocation rate, or even our findings in the MRI. If we do a good technique with a field of the Hill-Sachs defect, at least 75%, if we find this result after 6 to 12 months, these findings in the MRI, they're going to keep over time. They're not going to have like a lower scores in the clinical result or worst scenario in our MRI. Regarding the competitive sports, we can expect like around 90% of return to sport to any level, and about 2/3 to 70% of the patients, they're going to be able to return to the sport to the same or higher level. Other study with this focus, the competitive sport, they found a lower recurrence in high-risk contact athletes, again, comparing Bankart, isolated Bankart with Bankart and Remplissage. And very recent study in April 2021, they found better return to sport. They conclude this because they show that the fear of return to sport, which is important, the psychology of the athlete. Very often we have good results, no redislocation, but the clinical scores are lower, or sometimes even they don't redislocate. This is because they are not able to come back to the same level of sports because they are afraid of redislocation, because probably some proprioceptive information is telling them that they're not able to do the sport to the same level because of their risk of recurrence. Again, this last study, it showed the recurrence rate, it was 0% compared to 22% with the isolated banker group. So what is the downside of the Remplissas? Not everything is positive. Of course, we have some increase in the operative time, between 10 to 20 minutes, depending on the technique and your skills. You're gonna have an increased cost because of the implants that you use. You can have posterior superior pain, as we saw, at least in 10-15% of the patients, but this is comparative with the banker as well. The complication rate is like anecdotal, very low, below 1% in most of the studies, but you can reduce the external rotation, especially in abduction, and that can be important in throwers. There are several studies, they found a possible negative effect upon return to sports, especially among overhead athletes, and significant loss of external rotation after Remplissas, around 8 to 10%, that it can be even more in abduction, which make it difficult for a patient and athlete that they have to do extreme external rotation to be effective. It can be maybe not the best technique for them. Nevertheless, other studies, they haven't found a significant difference regarding external rotation, or even if they found some difference, most of these studies that I'm showing here, they affirm they were not clinically relevant for athletes. When we have to be more cautious using our Remplissas, as I said, in throwers, because of the limitation in extreme external rotation and abduction. And some studies told us that we have to be careful in revision situations. We can have up to 30% of redislocation rate even with Remplissas, and also the collision and contact athletes, we can have worse results even associating Remplissas to our banker. What is the best technique? The technique is not very difficult itself. I'm sure there are many ways of doing a Remplissas, as long as you get to feel the Remplissas defect at least 70-75%. I think 2 anchors are the best option in the more medial aspect of the humeral head. Other than that, you can do it the way you want. I have tried many things. Most of them they functioning well, but the last technique that I'm doing right now for my Remplissas, I think it's going to be published in the next book that ESA, the shoulder section, is going to come out with this book. So I'm interconnecting 2 anchors to create a bridge with my sutures, and I can close it down at the end of my procedure. So I use lateral decubitus for my Remplissas. Most of my instability cases, I use the classical 3 portals, posterior, anterior inferior, anterior superior, and immediately I put myself on the top of the head of the patient to look from the anterior superior portal. So now we are in the anterior superior portal. We can see a defect of the labrum at 6 o'clock. And also we can see our banker injury in this patient. We have seen already our Hilsatz defect. So my first step in this patient is going to be to fix my posterior inferior labrum. Here I'm preparing first my Hilsatz. You need to create a bleeding bone to have a good healing of your Remplissas. Next, I'm going to create an additional posterior superior portal to be more vertical for my 7 o'clock anchor for my posterior inferior. Very often, it's easier for me to reach the 6 o'clock position going from the back. The abduction of the shoulder to do a better Remplissas to me is around 70 degrees. And then very often when I have to do the banker, I move the shoulder to 45 degrees of abduction. So once the posterior inferior labrum or the capsule is plicated, then I go for my Remplissas. As you can see, 2 anchors in the inferior aspect. You put the 2 anchors through the same posterior cannula, and then you go back with your cannula, as you know, behind the capsule, and then you are going to interconnect the two. Sorry, you're going to recover the threads, and then you're going to interconnect your two anchors. I'm using this retriever. It works better than using a piercing retriever, because you have to get a lot of threads, a lot of sutures here. And this knotless anchor, they have a suture with a loop on it, and that loop is going to introduce the main suture inside the anchor. So you connect the main suture of one anchor with the loop of the other anchor. That way you create a double bridge with two sutures. And the good thing of this technique, you can have everything prepared, and at the end of your banker, you just have to pull the suture alternatively, and you're gonna close it down your hissas. So that's the preparation. I leave it there. I have tried in the past doing my remplissage and then go for the banker, but as you all know, normally it gives you less space to work in your banker, and you also can deteriorate your hissage repair. Sorry, your remplissage repair if you do that. I also have done in the past doing my banker and then trying to do my remplissage. But again, once you do your banker, your space for doing the remplissage is more reduced, so it's more difficult. So that's the best sequence. Posterior inferior capsule, posterior inferior labrum, prepare your heel sats, remplissage, do your banker, and then you close it, as you see, alternatively pulling from your threads, from your sutures. You close it easily at the end, and you don't even have to suture. But of course, you can do with regular double-loaded or single-loaded anchors. So in summary, remplissage has demonstrated in a solid manner that you can reduce the recurrent rate comparing to isolated banker in high-risk patients that have a glenoid ball loss below the critical size. We have multiple clinical studies demonstrated these results. We have different authors and different institutions showing consistent results. We have several systematic reviews, and we also have randomized control trials. You can expect a minimal motion loss, and normally it has not clinical relevance in most of the patients, even athletes. It has a very low complication rate, and you can expect long-term results if you get a good result from the first 2 years. But we have to be cautious in throwers because of the limitation of the sternal rotation. Also, you have to be cautious in patients with subcritical glenoid ball loss in between over 10 to 15%. And of course, in collision athletes and revision, you can expect a higher redislocation rate, and you may accept doing a bone block technique. Thank you so much.
So thank you, Gonzalez, for the nice presentation. Thank you, Marcos, also. Thank you for reminding us of the 4th Athens Shoulder course. We are waiting for you in the 5th Athens Shoulder course.
Thank you.
Thank you for noticing that important ideas come in common in the Athens Shoulder course.
Yes.
And so let's see now the results of the poll questions so that we can continue with the discussion.
So in the first poll, the 80% of the surgeons augment the classic banker repair, and 20% never augment this. And in the second poll question, 10% go for Latarjet in that specific case, and the rest perform soft tissue procedure. So, Geoffroy, which is your comment about all this? So, I know you're a French guy. I know you admire Latarjet as the most first guy. So, how do you feel about this?
Well, I would like to thank Marco and Gonzalo for this wonderful presentation. I would like to thank both of you for inviting me. I'm very happy to be here. I remember at this last meeting, you told me, okay, you're going to come at the next meeting, and nothing happened because of the pandemic. So I'm very happy to be with you tonight. Thank you for inviting me. Yes, you're right. I am a French guy, and I am very, very, very comfortable with la target that I'm doing very often. But having said that, I have some indication for arthroscopic stabilization of the shoulder. And I have to say that listening to Marco, I say myself, why I don't do that? But I have some questions that you have to answer me to try to convince me. I have 2 or 3 questions. The first one is just a clinical question, because me, when I go to surgery, I want to plan everything, and I don't want to change my mind during surgery. I don't like that. So I want to be sure when I go inside the joint, if I go for arthroscopy, I know exactly what I will do. So you said that a good indication is for capsular deficiency. I know what is hyperlaxity. I know what is hypermobility, which is quite different. But do you have any clinical exam to define what is capsular deficiency?
Capsular deficiency, no. I don't have a clinical examination for capsular deficiency. I can see capsular deficiency only when I go exactly. I can find when I go inside the joint, I see there is a poor capsule. But I don't
so
have.
It's only when you are inside the joint that you see the capsule.
Yes.
It's based on your experience. It's based on your eyes, and you say this capsule is not good.
Yes. But obviously, it's my experience, my eyes. I don't do. I'm not a microscope.
We can say that capsular deficiency.
When I go inside, I see that the capsule is no good. Maybe possible because multiple dislocation, and or maybe there is a guy that has poor capsule, not very good capsule, anatomical good capsule, and multiple dislocation. Both reason.
When I do say that it's very subjective. It's not very objective.
It's subjective of my experience of many years of going inside the joint and having that and seeing that, obviously. But there is no clinical examination to understand, or even if you do an arthro MRI, it's very difficult to see if you. It's not impossible to see if you have a poor capsule.
So now my question is based on your experience.
Yes.
I've got the feeling that more dislocation you have, and more distance there is between the first episode and the surgery, the more the capsule is deficient. So my question is, do you consider that there's a maximum time between the first dislocation and the surgery to consider that the capsule is still efficient?
I think I don't exactly understand what is your question. I don't think that really is important. It's very important. The first dislocation and the surgery you're seeing. You're telling me the first dislocation and when you go into surgery.
The delay between the first dislocation and the surgery.
Obviously, might be a relationship between the first dislocation and when you go to surgery. But even multiple dislocation, and you can or multiple subluxation, because you can have even a subluxation, non-regular dislocation. And I think that this multiple traumatic behavior of the humeral head in the anterior soft tissue structure of the shoulder can get a poor capsule.
So I have got one last question, which is two questions in one.
Yes.
Gonzalo told us that the remplissage is a tenodesis. And I've got the feeling that what you are doing is a tenodesis also.
Yes.
I can't understand why you don't have any limitation of external rotation.
No. Wait. I don't. Yes, in fact, I'm not saying that you have any limitation. You don't have a clinical limitation of the external rotation, but you have a limitation of external rotation. For example, if you have an external rotation, an hyper-external rotation of a guy that goes to 90 degrees, when you do the ASA technique, you have obviously a situation of a scar tissue of the tenodesis, and so the external rotation of the guy with the arm abduction, if you do again the Coutan test, you have an external rotation. Instead of 90 degree, you go to 65 or 70 degree. You understand what I mean?
Okay.
So you don't have, my expression, well, you don't have a pathological limitation of external rotation. Okay.
So that's my last question for you.
Yes.
Is there any technical trick during the surgery? For example, do you put the arm in a specific position to organize or to reduce this external rotation?
When I put the arm, I use lateral decúbitus, and I put the arm in neutral rotation, and when I pass the tendon, slightly flush to the glenoid surface, so you don't tie too much the upper third of the subscapularis tendon. I suppose that usually, as I showed in all that paper, the subscapularis tendon in patient is not always the same. Even the capsular tissue, you can find subscapulari in patient, usually in patient with hyperlaxity. When you have the Coutan test positive, you have usually a subscapularis tendon that is thin and that is very lax. Obviously, the big one goal should have been to do microscopic biopsy on this subscapularis tendon to see the structure and the behavior of the structure of the this subscapularis tendon. I was talking one time with Rodeo, who did in the hospital, who is the chief of officers for special surgery and he did some studies about histological study about the behavior of capsule in swimmers, and he stated that he told me that in these guys you can find the structure of the anterior capsule and the anterior subscapularis tendon that behaves in a different way, but microscopically, and the historical articles that I showed, they stated that the subscapularis tendon, because of multiple dislocation or because you have a constitutional anterior hyperlaxity, is different from a normal subscapularis tendon.
So I think it's not
sorry,
a question of.
Manos. And the thing is, you don't have as the Angelo and Hawkins article that stated that the putty-plat was a surgery that you should not do because you had a limitation of external rotation. This is not a putty-plat because you don't deal with the entire tendon, but you deal with the upper third of the tendon, and the 2/3 of the tendon, you don't touch it.
Yes, in Greece we were familiar with putty-plat during the 80s with the putty-plat procedure, and the limitation of external rotation that we had with putty-plat, it was a non-functional limitation of external rotation. The external rotation limitations that we have with ASA or with remplissage is not disturbing the function of most of the patients. It's not a problem, a clinical problem. Maybe in baseball players or in patients that they need an increased external rotation, this may be a problem, but it is not the usual population that we treat. And I have the impression that if you continue with the rehabilitation, stretching the capsule, even with ASA or Remplissage, you are going to gain the external rotation that it is missing. The reason that the external rotation is missing is that the patients have no motive to continue exercising to increase the external rotation, because we see that in patients that they are, for example, volley players, and they continue the rehabilitation by training in volley, they slowly increase the external rotation to the limit that they feel that they don't have a limitation in function. And this is important. And also, Geoffrey, it's not a matter of having a bad capsule. What we see in a bad capsule is, we know that after, and every shoulder surgeon knows that if you have many dislocations, you have a capsule that it is stretched and of not so good quality. So it's the decision for us for a soft tissue procedure, at least for us, is a patient that it is not engaged in very active sports, that he is not having a major bone loss, that he is not having many dislocations, and for these patients, or that he has a constitutional laxity. And in these patients, I think a soft tissue procedure, like a NASA augmenting a Bankart or a Remplissage augmenting the Bankart, is giving a good functional results with a very low reduction, a very low redislocation rate. And this is comparable to bone procedures, either Edenhibinet or Remplissage or Latarze, with a lower possibility of major complications. Because the problem with the bone procedures is that they have very few complications, very few redislocation rates, but if you have a complication, it's difficult to treat. And this is what, when we talk about overtreatment with bone procedures, we don't say, why, what is a problem to overtreat? Why not to do to all the patients a bone block or a Latarze? We could do it. And we expect to have very good results with this type of procedures. But we overtreat a lot of patients in the sense that they put them in a risk of serious complications that it's going to be very difficult to solve. And this is what at least restricts me for going to every patient for a bone procedure.
And we are talking about
and 10% bone procedures. Now we are doing 40% bone procedures and 60% soft tissue procedures. We are going to bone procedures because we feel that we have better results, less redislocation rate. Manos and had gathered our patients with Remplissage during 2010, and we had a dislocation rate of 6%. And now, by increasing the number of bone procedures, we have a dislocation rate of 3%. And this is what we see at the end.
We are talking about external rotation deficits, like about ASAP in this moment. But we have to think in which technique we don't have an external rotation deficit. Even in this isolated Bankart, it's described like 3 to 4 degrees of external rotation deficit. And if we recall, it's a study from Marco actually, where he compared Latarze and ASA And if you see, there was no significant difference. But if you see the results, you see like in the Latarjet group, there is a 9 degrees of external rotation deficit, whereas on the other side, in ASA, there was just 8 degrees of external rotation deficit. It's not significant again, but it's almost the same. So in every technique that you use, that you're going to get an external external rotation deficit. And at the end of the day, is if the patient has a problem with it or not.
Yes. For me, Christos, it's impossible to see the difference between 8 degrees and 10 degrees
Exactly.
of external rotation.
Exactly.
The
If
problem
you don't
is,
tell the patient, he's not going to know.
yeah, if the patient feels that he has a problem, or if he feels he is not having a problem, this is the problem that we face. If you have a patient that has 95 degrees of external rotation and feels that he has a problem, then it is a problem that we have to solve. And if a patient has 80 degrees of external rotation and is not feeling that he is having a problem, this is not a clinical problem.
And not just that. I know that in France, like Latarjet is like it's like the Bible, but kind of. But on the other side, even Latarjet has some external rotation deficits. Like that's why I recall this study by Marco, where he compared these two techniques.
I totally agree. I don't say that there is no indication for soft tissue procedure. In the literature, you're right. You have something like 10 degrees limitation of external rotation in the Latarjet, and in the review of literature, a little bit more for the Bankart. So, because it's normal, and I think it's mandatory. If you don't want to dislocate one more time, you have to limit the glenohumeral external rotation, not the global mobility, because you've got the movement of the scapulothoracic joint that can compensate, of course. But to have a good stabilization, you need to have limitation of the glenohumeral external rotation. I totally agree.
Geoffrey, can I tell something? 1 second.
Yes,
no, in the indication of the ASA, there was a slide where I told the indication are bad capsule, hyperlaxity, global loss less than 15%, and contact sports. I don't use as a procedure in throwers. So because you have obviously a slight limitation on external rotation, so the athletic gesture of a pitcher, you cannot do another technique. So these are the indication. The second thing, I'm not saying that Latarjet. I say Latarjet is a very good technique, but especially a brilliant technique because it saved a lot of instability. I saved a lot of shoulder instabilities. But the question is, I have two questions. The first one, biomechanically, I read a lot of your papers, and you are a scientist. So I want to ask you, the stabilization action of the Latarjet is due to the conjoint tendon or to the coracoid? First question. And the second question is, when you don't have a bone loss, and you have a situation when you have to do a Latarjet because you don't want to use an augmentation soft tissue, you create a bone loss on the glenoid to help the healing the coracoid or not?
Okay, so for the first question, I think that on the cadaver, you have many answers. But regarding the stabilizing effect of the Latarjet, in most of the case, it's a soft tissue procedure. I don't know if it is the conjoint tendon. I'm pretty sure that the effect of the conjoint tendon on the subscap, that is augmenting the power of the subscap, is pretty efficient, and you have a more efficient subscap that is doing the effect of the inferior glenohumeral ligament. When you come back, for example, you go to a revision for a Latarjet, you do not find anything. It's just a big tissue full of collagen, but you can't find the conjoint tendons. You don't know where is the subscap. So you have a big scar tissue, and probably this element with this very aggressive surgery is at least, I think, 2 or 3 months after the main element which is stabilizing, because the sliding effect, you don't have it anymore. Okay, you've got just one big scar tissue. So you have probably some stretching of the soft tissue behind 3 months after. So the stabilizing is probably much more related to the soft tissue. Why? Because they are lowering the subscap. It's one element probably. Because you are doing a big soft tissue anteriorly, and even if you have a huge dislocation with engaging Hilsatz, you know that if you do a Latarjet, you have no more engaging phenomena with the Hilsatz lesion because the unit is very big. So it's a multimodal treatment of instability that is very efficient. I think that the soft tissue is the main element. Now, regarding the indication, regarding
Thank you for your answer.
Okay?
Thank you for your answer.
Yeah, I'm pretty sure about that. That's my idea, my religion. We cannot prove it, but I think so. Now, regarding the patient who has no bone loss, I have to say that I do some Bankart repair. I don't do augmentation, but I do some Bankart repair in very specific indications. No bony defect, for example, first time dislocation, good inferior glenohumeral ligament. So I think with a delay or first time dislocation with a delay that less than 1 year, I think that the soft tissue are still good, and I try to fix it to avoid complications that can happen with Latarjet. I agree with you. But if it's a guy who is a very sportive guy, collision sport, and who has no bone loss, I will Latarjet if he is 19 years old, because I know that the recurrence rate is very, 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 very low, and the patient wants no recurrency. So you've got biomechanics, you've got ideas, and you've got clinical results. If you do a Latarjet, like it has been described by many previous people, it works. And if your technique you create, Marco, demonstrate that 10 years after, because we need to wait at least 5 years for instability, you all know that we have a recurrence rate in soft tissue procedures that start at 2 years and can be for something like 10 years. After 10 years, we can consider that we are pretty efficient. So if you demonstrate that at 10 years you have the same recurrent rate, I totally agree that it can work. And I will be more aggressive than you, because you have a very efficient procedure. For example, when we do a TRIA procedure, which is a pure tissue procedure, we don't care about the bony defect. So we just know that for Bankart alone, the bony defect is not good. But your technique, augmented Bankart technique, should be probably a way to assess also some bony defect, because you are more aggressive than just the Bankart.
In the
Okay,
States,
wait, Marco, wait a minute. Let me do some questions from the audience. So, Gonzalo, do you calculate preoperatively in a regular fashion the on-track, off-track lesion? Do you do CT in every case in order to see the Hilsatz lesion if it's on-track or off-track?
You can do it easily in the MRI or the CT scan, but to me, it's not the only objective data that I use to take my decision. But it's not very difficult to use. You just multiply your glenoid length by 0.83, and then you get the axial cut in your MRI to see the Hilsatz. But to me, it's just one more data. I have to see if this is a collision athlete. I have to see his hyperlax. I have to see his revision case. As Geoffroy said, I have to see if he's 2 years redislocated. So it's one more data to me. But I do.
So you use the ICE score, because these are the parameters of ICE score?
Not literally, because you can use the ICEs, but nobody knows what is the threshold. You know, some people is in 4, Geoffroy probably is in 2, in other parts of Europe it's 6. I don't know. So what I use normally when I have a bone defect below, I would say 10%, which is around 2 millimeters of anterior glenoid bone defect. If the patient has not one of those high risk factors, as I said, I will go for a soft tissue procedure. But if he is like more 1 year already dislocating, collision athlete, very hyperlax, revision cases, I will do a bone block. Lateral jet is my choice. And the patient with more than 10-15% of glenoid bone loss, which is in between 2 to 3 millimeters of anterior glenoid, I go straight for lateral jet. Because of, as Geoffroy said, I mean, you cannot control the redislocation rate as soon as you have more than 10% of glenoid bone loss if the patient is a high-risk patient. And it's very frustrating to have like a 30% of redislocation rate. 3 out of 10 patients, they're going to come back very pissed. And that's a lot of patients. So my mentality, I do over-treat the patient, as Manos said. So my mentality is a kind of French mentality because I'm a French school. As you know, I have my mentor, Dr. Lafos. And what I try to do is like have a strong command of the lateral jet technique. So my complication rate is very low. And that's why I can go lower with my threshold doing this technique and have like happy patients. So I don't know if I explained myself.
Okay, Geoffroy, you have published since a decade that you have cases with pain, posterior pain after remplissage. Why do you believe that this pain is due?
I think that you have an impingement that is induced by the modification of the location of the cuff. You have just like a tenodesis. That's why I am wondering about that. When you are putting your arm in abduction or external rotation, it's not in pure external rotation. When you are pure external rotation, you have no pain. But in abduction and external rotation, you induce a posterior-superior impingement with the cuff, you know. And I think that's why. And I have to confess that I have seen more than 3 cases of patients that have a tear of the infraspinatus, probably related to that were after remplissage, and they were probably related to a cuff tear induced by surgery for a young patient. That's the first thing. Remplissage is very difficult. I have done some. I disagree with Gonzalo. I think it's very tricky to find exactly the good position where to put the anchor because the space is small. I do like you. I put my anchor, I made the bancard, and I pull on the posterior. I like to go in the subacromial space to tighten my suture because I don't use the same implant that you. But I think it's difficult. And sometimes you are very confident during the surgery, but you modify the anatomy. So when you modify the anatomy, you have some side effect. It's mandatory, you know. So if you do that, you have pain because you have impingement. I think that's why. And we said that it disappears with time. And if we see the patient during the first 2 years, you have impingement, and we contact all those patients by phone on 10 years after, but they are older. They do not complain about pain. They are stable. It's very efficient. But you have to think about the fact that you should stop their sport activity when they are 18 years old. That's why currently my indication for remplissage is not for young people. It's just for the example typical is a guy, 45 years old, skiing. He has a dislocation, no bony defect. He has Ilsachs lesion and an apprehension. This guy, I will not do, of course, a bone block procedure. He has anterior chronic instability, huge apprehension. I will do a bancard on a remplissage because I know that it's not very active. That's, for me, the perfect indication of remplissage.
Okay. Marco, do you have any evidence of subscap tear after the scar tissue formation after the ASA?
No tears of subscapularis tendon, no.
Marco, I have a question as well. Like, do you have cases where you have a big Ilsachs defect where you consider of doing a remplissage instead of doing an ASA or doing both? Actually, in bipolar lesions where you have a big Hill-Sachs defect?
If I have a big Hill-Sachs defect and I'm afraid that I can have an off-track lesion, I do a bone block plus ASA procedure, or arthroscopic. And I've never done in my life bilateral tenodesis, because I think that you can have rotational restriction with bipolar tenodesis. And
because I've tried it. Manos has tried it as well. I think I told you already. And
yes,
there is no external rotation deficit there either. That's the thing. I had actually just 4 cases that I've done, and they're totally happy with it without using any bony procedure. And I have to say, like, I don't know why, I cannot explain it, but it works. It works.
Marco, I've got one question also for you. I think that you have reviewed your patient a long time after, and you have done a CT scan or everything. Don't you have any fat infiltration of the upper third of the subscap? Because we know that at the beginning of the Latarjet in France, we are cutting the tendon, and we have some problem. Because your tendon is not moving anymore, I am wondering about the quality of the muscle of the upper part. Do you have any data with a CT scan to see if you have any fatty filtration 4 or 5 years after?
No, I did only some MRI, ultra MRI, as I showed you, to see the reduction of the capsular volume. And I did some only MRI in recurrence of ASA, but I didn't do any study about
the muscle.
Of the muscle. No, because I didn't do, because if the patient are okay, I call them to see if they're okay. We did follow up to see if how was the situation and stuff, but we didn't do MS. We did MRI in the first paper to see in some first paper to see how was the position of the anchor and how was the, but we didn't do all the patient MRI control. So I cannot know if in some patient or few patients could be MRI problem of the subscapularis tendon.
So, and I have one more question. You know, when we do a lot of Latarjet, we have many people who are, of course, very happy, very stable, but with some kind of weak subscap. You have a lift of test which is less strong than the other side, and we have a belly best stress also with sometimes different, because we go through the subscap. Do you have any experience in your technique with a weak subscap after having done this tenodesis?
We did not measure the strength of the subscapularis tendon, but with an objective manner, okay. But with the clinical follow-up, we did not find any weakness of the subscapularis tendon in front of the contralateral. But we didn't do any. We were thinking to find with some neurologist and we were planning to do and to a study to see if with the electromyography to see if there was an objective behavior of the subscapularis tendon after the technique, but it was very difficult to do it in reality, this study, so we didn't do it.
However, Geoffroy, because I measure the strength of the subscapularis after ASA with the dynamometer.
You did it?
As I did it, but there's no different. There's no different with the other side.
I think that when we do the ASA, we take the upper part of the subscapularis.
Because of this problem.
And this upper part of the subscapularis is not reducing the strength of the subscapularis. Even if you have a small tear in the upper part of the subscapularis, the patients usually are not having a positive lift-off test or loss of strength of the subscapularis. They have pain due to the conflict with the biceps. what we do with the subscapularis, I think, is not that we we stretching the subscapularis. We reestablishing the connections between the subscapularis and the ligaments of the interval, the coracohumeral and the anterior superior glenohumeral. And there are connections there that they become lax after some dislocations. And when we put the when we do the ASA, in reality, we reestablish these connections and we tighten the interval by contracting the subscapularis, is tightening the rotator interval. And I think this is the way it works.
Okay.
Not by
Sorry, this is, but I showed in the presentation that the triple effect of the ASA. But the important thing that you restore the coracohumeral tension, because you have a laxity of the anterior inferior translation. So if you do this surgical this surgery, you restore the tension of the coracohumeral ligament and you tighten the interval. You understand what I mean?
In reality, you
the principle is
reestablish the
similar
tension
to
in the interval.
closure. Oh, sorry.
Okay, I've got one last question for Gonzalo. You said that based on the review of literature you have done, that revision is not good for the Hill-Sachs remplissage. In my hand, it's one also indication when you do a Latarjet procedure that you have a recurrency, that when you have a bone block which is in good position, well healed, and you have a Hill-Sachs, that should be not at the same time, but in case of recurrency, a good way to treat a recurrent dislocation with normally and well-performed Latarjet. I don't know if you have any experience or any comment on that.
What is the question exactly? Tell me again.
The question is, you said that it's not a good indication to do a remplissage in revision cases. At that point, I would like you to say to tell which kind of revision, because for me, it's a very efficient procedure for revision of well done and well healed Latarjet. So, which kind of revision you don't like, or we shouldn't do?
Well, the first thing is to evaluate what was the failure. But if you see like a good banca with remplissage, well done for a good surgeon, to me, it's a straight, probably a bone block procedure, like a Latarjet. I said that it was not the best technique because of the numbers that literature show, because they show that in revision situations, the redislocation rate, I think it was a couple of papers, one from, it was Wadi Sawa involved, and they detect a 36% of redislocation rate, banca plus remplissage, and there was another paper.
But revision of which kind of surgery?
Well, I don't know what they did. Sorry,
okay.
I didn't read the paper, but to me, it would be a Latarjet. Okay. But I saw in several papers the same numbers, 30% redislocation rate, around that.
I think like what they say is that make the revision of a Bankart repair alone with a Bankart with a remplissage is probably not efficient. But I think that when you have a failed Latarjet, which is well in good position, but a big Hill-Sachs, it's a very useful procedure to prevent recurrency, because I don't know what else to do.
You mean like you do a bone block and remplissage to combine both?
Before closing, we have the $1 million question for Geoffroy from Berthe Boy, and I thank for this question. So you said before that you don't perform remplissage because it is a non-anatomic procedure, but you perform Latarjet, which is also a non-anatomic procedure. And Berthe needs your comment on this.
No, I didn't say that. I said that remplissage is not an anatomic procedure. But I didn't say, I know Bert, I know why she said that. But no. Yeah, remplissage is not an anatomic procedure. Latarjet is not an anatomic procedure. ASA is not an anatomic procedure. DSI is not an anatomic procedure. In France, we don't consider that we have to do anatomic procedure. We consider that we have to do efficient procedure. You know, when you make when you have an ACL tear, you don't do an ACL repair. In France, we do a graft, and you make a Lemaire of reconstruction of the lateral ligament because it's efficient. So it's the same thing. When you do Latarjet, it's absolutely not anatomic, but clinical results demonstrate that it's efficient. The same thing, the procedure of Marco is not anatomical, but it works. We are quite different from the American people who think that they have to restore anatomy. We all know that restoring the anatomy in most of the cases, for reasons we can discuss together, but in another mini battle, is not always efficient. Probably because we do surgery later than American people that restore immediately. I always make the comparison, with the lesion of a ski tomb. When you put a tear of your ligament of the tomb, when you are in the short delay, you can restore. When you are in a medium delay, you make a ligamentoplasty, and when it's too late, you make an arthrodesis. Everyone is working, but it depends on the delay. And the same thing for the shoulder. We are speaking about what do you do for this patient, but the delay and many other factors are very important. But what I am sure is that restoring the exact anatomy has some indication, the very small one, on the Bancart alone, probably because, at least in France, during many years, we were not doing surgery at the first time episode, is not efficient. Probably now that we are doing Bancart repair, very complex anterior and posterior, but very shortly after the first episode, it was my first question to Marco, what is the good delay? If you do that very shortly, it's efficient and we can restore anatomy. But when we are the recurrence, when we are waiting, when you want to see if the patient can recover without surgery, when we come to surgery lately, restoring anatomy is not working. It's pretty sure.
Only 1 second, Manos. Only 1 second, Geoffroy. I didn't exactly pick up your answer at the last my question. When you have a patient that is risking and there is no bone loss, and you do a Latarjet, you create a bone defect on a glenoid to fix the coracoid over there or not?
Yes, I create. No, I make I remove the cortical bone. Yes.
Yes.
And I remove bone that is less than 1 millimeter. But yes, I do it.
Okay, this is the question. So, thank you very much.
Thank you. We are run out of time. It was a very interesting mini battle, as always, and I think we all agree that it's a matter of indication and not for applauding a procedure or another one. And if you have proper indication, you have good results, and this is the key for successful surgery. Thank you, everyone, for being here with us.
Thank you.
Thank you all. Thank you for being here. And let's meet all in Athens next May. Bye-bye. Good night.
Pleasure.
Bye-bye.
My pleasure.
Thank you for attending.
Bye-bye.
See you the next episode,
Bye.
which is dedicated in chronic massive rotator cuff tear with functional shoulder. Would be very interesting subject. You can always follow Athens Course on Facebook and LinkedIn to stay in touch, and follow BMed because there are many interesting webinars hosted in the forthcoming period. Thank you once again for attending.
Thank you.
See you.
Thank you. Goodbye.
Bye. Thank you all.
Bye-bye all.